Welcome to the Occupational Health for Ebola Care Team's webinar. My name is Richard and I'll be your operator for today's call. At this time, all participants are in a listen-only mode. Later, we will conduct a question and answer session. Please note that this conference is being recorded. I'll now turn the call over to Nick Falco, ACOEM Director of Business Operations. Nick, you may begin.
Thank you, Richard. Today's webinar, Occupational Health for Ebola Care Teams, has been developed by ACOEM's Medical Center Occupational Health Special Interest Section. Our presenters will include Dr. Melanie Swift. Dr. Swift is Assistant Professor of Medicine at Vanderbilt University, where she has been the Director of the Occupational Health Clinic since 2001. She oversees occupational health programs for over 25,000 employees and serves on the institution's Ebola Planning Committee. She is the current chair of ACOEM's Medical Center Occupational Health Section. Our second presenter is Dr. T. Warner Hudson. Dr. Hudson is the Medical Director of Occupational and Employee Health for the UCLA Health System and campus, around 50,000 employees, including 4 hospitals, 160 clinics, and numerous campus research labs. He supports the UCLA BSL-3 labs, the Reagan Hospital Ebola team, and has extensive knowledge of California workers' compensation laws, ACOEM guidelines, NIOSH, OSHA, and EPA regulations, and hospital epidemiology. Dr. Hudson is also a past president of ACOEM. Our third presenter is Dr. Michael Sawrey. Dr. Sawrey is a specialist in occupational medicine and infectious diseases in private practice in Rockville, Maryland since 1987. He is the Medical Director of Occupational Health Consultants and is a clinical professor at Johns Hopkins Bloomberg School of Public Health and the Uniformed Services University of Health Sciences. Dr. Sawrey is also the recipient of numerous awards and decorations from the Department of Defense, State Department, as well as state and local governments, including the Humanitarian Service Medal. I will now turn it over to Dr. Melanie Swift to begin. Dr. Swift, you may begin.
Well, good afternoon or good morning, everyone, wherever you may be in the country. I will just dive right in with an outline. Briefly, we're going to discuss the personal protective equipment just to set the stage for why a medical clearance would be indicated and the sorts of things we need to think about. We'll touch base on what the Ebola Care Team actually experiences and should expect and be prepared for when they undertake this work assignment, which at this point is by and large in most institutions a voluntary experience. Pre-participation medical clearance will be next, and along with some advice for pre- and post-shift evaluation, and then exposure management. So thanks to UC Davis, who's put out the best illustrated photograph I've seen yet of the full array of personal protective equipment. You could do an entire webinar just about Ebola PPE, but for today's purposes, I just want to point out the complexity of it and the burden of it physiologically. In this illustration, the person is wearing a powered air purifying respirator. An alternative that some facilities might choose to use is an N95 respirator with a full face shield and a surgical hood. Either way, that is something that can be fairly onerous to wear for a prolonged period of time, which is different from our usual short-term duration use of personal protective equipment in patient rooms. Many of these patients who are extremely ill really require a fairly constant nursing presence in the room. So people are spending anywhere from 2 to 4 hours in this garb. The impervious gown and the impervious coverall that this person put on get very hot because they are impervious, they don't breathe. So all that needs to be taken into consideration when you're preparing your team to take on this work assignment. Another element of caring for Ebola patients that is unique among what we typically do in the hospital is the monitoring of the healthcare workers for potential Ebola symptoms. Monitoring of these caregivers consists of twice per day temperature checks and a symptom survey. And the public health Service has divided monitoring into active monitoring, in which an individual reports in to the public health authority, and direct active monitoring. In direct active monitoring, the public health authority or their delegate needs to directly observe that person at least once per day. And then the second check may be by telephone. For healthcare workers, direct active monitoring is what is required. Active monitoring is what you may see in returning travelers, for instance. And this monitoring isn't just during their work assignment while caring for an Ebola patient. It persists for the incubation period, or 21 days after assignment. And you're going to see that that's one consideration that needs to be taken into account when you do the initial evaluation of these folks. I'm going to highlight just a couple of experiences or situations that will impact the healthcare worker. Just the fact of caring for an Ebola patient automatically means that the person's signing up for direct active monitoring for that entire time period of care plus 21 days. Another situation that could arise, which Dr. Sari will go into in more detail, is they could sustain a high-risk exposure. And should that happen, the impact on the healthcare worker would be rather dramatic. It would include movement restrictions, including no use of public transport, not going into public places, not coming into work in person, and any travel would have to be approved and coordinated ahead of time with public health authority. And that's aside from any post-exposure treatment and medical management that may be indicated. Should that healthcare worker develop potential Ebola symptoms, then they need to be prepared for rapid isolation and testing and treatment in coordination with the CDC. And for some people, that flexibility to go into a rapid isolation situation may not exist. Therefore, the Medical Center Occupational Health section felt that we needed to establish some guidance for those occupational health professionals who are clearing these workers. And so we have drafted guidelines, which are really consensus guidelines for the medical clearance of these folks. And on this slide, you'll see all the contributors to that document. That document is available on ACOEM's IDEA Marketplace. Just briefly, the conceptual framework of this is that we really could not and did not want to develop a comprehensive list of diagnoses that would make someone disqualified from caring for an Ebola patient. It really requires a comprehensive medical history and then a balanced assessment of the individual's risk. The only absolute disqualifier being pregnancy, which Dr. Hudson will go into. So the main recommendation is that you obtain the full medical history, and then you're going to apply certain principles and then educate the healthcare worker about the risks. Again, these are largely voluntary assignments, so being well informed of the risks is 99% of the time what we need to do. We will need to consider not only medical factors, but personal and social factors. Are they going to be able to comply with direct active monitoring? Do they have upcoming travel planned? Do they have a contingency plan should they sustain an exposure and need to be isolated? And can they tolerate the potential limitations on movement that an exposure or symptoms would warrant? These clearances need to be in association with any other required compliance, most notably the respiratory protection program. So the clearance that Dr. Hudson's going to go through does not take the place of a clearance to use the respirator, but would be an adjunct to it. In addition, you want to make sure folks are vaccinated against those contagious illnesses to which they might be exposed, which could cause a fever or symptoms and could complicate their monitoring period. Because none of these diagnoses that we'll discuss are a clear and distinct contraindication, it is important to consider the severity of the condition, how well their symptoms are controlled. For instance, not just do they have an insulin pump, but how often do they need to manipulate it? How well controlled is their condition? Therefore, collaborating with their treating providers becomes very important with appropriate consent, of course. As I said, disqualification will generally not be required because many individuals, once informed of their risk, may self-select out of the process. So our goal is informed decision by the healthcare worker so that they really are aware of the exposure risks, including needle sticks, and this process should be interactive and ADA compliant. One other consideration is that in the exam room, in the clinic, reviewing questionnaires, talking with individuals, you're only seeing a small piece of the picture. You're seeing them for a relatively brief period of time. Trainers and observers that are going through drills with them and are going through skills training with them will have a uniquely helpful perspective because they'll have the ability to actually observe the person donning and doffing their PPE, and they may see that someone really is not able to do that safely. They will see them in their personal protective equipment for a much longer period of time and may be able to see that they're becoming anxious or uncomfortable, so that you might not have predicted in the office. So having an open line of communication with those direct observers is very important. So with that, I'm going to turn this over to Dr. Hudson.
Thank you very much, Melanie. Welcome, everyone. I want to also thank the large group of people that contributed to this guidance document, and just remind everyone that, as Melanie said, this is in addition to respirator clearance and, importantly, training. And just a quick comment on the training piece. Our BSL-3 trainers commented that only a third of the people who went through the donning, doffing training passed the first go-through. Then one of our directors of our emergency rooms here said that he failed the first time. He began to get it right the second time. The third time, he thought he got it right, and he hoped that the memory would stick with him well enough to do it correctly the fourth and fifth time, and he felt that really people should only do it who've been through the training about 5 times. And I thought that was pretty important information coming from someone who comes out of the emergency room kind of cadre of people that tend to be at times very confident, even to the point of cavalier about some training things. So with that background, let me kind of go through the details of the clearance process. So in terms of logistics of the clearance process, ideally an occupational medicine physician would be doing this medical clearance process. I think that a nurse practitioner or an occupational health nurse could certainly do much of this and be supportive of it. In terms of data collection, a questionnaire is helpful to gather a lot of the background information about medical history, medications, social situation. But really, in the end, you're going to need to really review the medical history and meet face-to-face with the person to go through these things. My experience is that a lot of people will voluntarily jump into wanting to volunteer for this work, and then as they think through the details, things begin to pop up. We've all had this experience with people who have volunteered for smallpox vaccine, then realize their psoriasis is not well controlled, or their cycle of chemo is coming up, et cetera, et cetera. So this really gives the healthcare provider a chance to carefully bow out once they've had a chance to privately sit and think through things. So as Melanie said, we don't have an exhaustive list of conditions to go through. What we have is sort of categories which would be considered. The first of which is upcoming medical treatment. I mentioned chemo is one that's common. Cycles of chemo have to be scheduled. Planned surgery like gallbladder surgery may be pending. You certainly don't want somebody to have a gallbladder colic attack in the middle of Ebola care, so this is an important category to go through. In addition, there are a number of conditions and situations which make it quite hard to correctly don and doff. Marked obesity, severe back stiffness, joint stiffness, ankylosing spondylitis may be the kinds of situations that would make it very hard for people to put on and take off all of the ensemble in a safe manner. There are quite a few conditions which may interfere with just safe wearing of this ensemble for the whole duration of the shift. Things like severe anxiety, claustrophobia, things that we consider with the medical clearance for respirators, but that might be a different set of fears around the Ebola ensemble for the duration of the shift, whether that be 2 or 4 hours or what have you. There are also a variety of conditions which might be of concern while giving care for an Ebola patient in terms of potential loss of consciousness or cloudiness, all the things that we worry about with our DOT drivers, poorly controlled diabetes, especially insulin-dependent, positional vertigo, seizure disorders of almost any flavor that's not well controlled, and the list could go on and on, but I think you get the picture on that. There are a number of conditions that, of course, could be worsened by the stress and workload of the ensemble, plus the stress of the work itself. A couple to mention, like angina and COPD, are pretty obvious, but the list gets quite long, and people tend to come in with things that you haven't thought of as we go through these. Do the BSL-3 clearances for our BSL-3 researchers and workers every year, and it's amazing the list of exotic things people have that they wouldn't share with their coworkers. There are a lot of conditions that might cause people to need to exit the Ebola treatment unit. Lactation, breast pumping, insulin pumps, urinary frequency from a bladder infection are just a few that kind of come to mind. But it's important to think of these things because you can't just quickly exit. It takes a good 15 minutes to put on and another good 15 minutes to take this stuff off. And somebody's watching you. You've got to do it very carefully and not make mistakes. So it's not the kind of thing where people can dash in and out because something comes up medically. There are also some conditions which might put the person at increased risk of infection, a variety of immune-suppressing conditions, including poorly controlled diabetes with blood sugars that range above 200, 250, A1Cs are above 7.5 or 8, certainly 8.5 begin to impair some of the white cells. So the conditions that put people at higher risk of getting infected need to be considered. And then to the social kind of context that Melanie brought up, if the individual is the sole caregiver and has no backup for a dependent child or adult or even pets, that can be quite a problem when their travel needs to be restricted. Planned travel, jury duty, there are a lot of things that come up in people's lives. And when you add the month of potential duty plus another 21 days, and you've got, maybe 100 or even 200 people totally on the team, there's a lot of people to sort of think through, and life carries on, so people need to carefully plan these things. So there are also some conditions that might make it hard to figure out whether it's the condition flaring up or Ebola, a febrile illness that's ongoing, inflammatory bowel disease, Crohn's or ulcerative colitis are a few that come to mind, but there are certainly many others that you wouldn't want to put people into the Ebola team while they have ongoing conditions like that. Also, there are conditions which might complicate the treatment or become more severe if a person got Ebola. The survival rate for pregnant women getting Ebola is almost nil. It's quite bad, so we probably would not want to put anyone who is pregnant on the Ebola team. Coagulopathies certainly add an additional risk if somebody got Ebola and already had an underlying coagulopathy or was on anticoagulant drugs. So those are some of the categories of conditions that we think about. And then when the clearance process is done, you're going to want to fill out a typical clearance form. This is one example. So the people are either cleared without restrictions, they have restrictions, they might be pending, you're getting other information from their personal doctor. cardiologist, for example, and occasionally they might not be medically cleared. Also, after they are cleared, they need to be reminded, as we do with our PSL3 team members, our DOT commercial drivers, that new conditions or situations, a broken arm in a cast, for example, a motorcycle wreck with a broken leg, people don't always think about these things that happen after they signed up for the Ebola team months ago, and they're happily going around work with their cast in their arm, and they're still on the Ebola team. So people need to be reminded of conditions that come up or any acute symptoms that have emerged, UTIs, URIs, and then we think it's a very important step to have a pre and a post-shift health and safety check to make sure this is part of the workflow to assess the exposure risk itself, the impact of the PPE, and how the person is doing. So the pre-post-shift health check is really to look at the readiness to don and doff the PPE and to make sure that they are prepared for what they're going into at the point of donning and at the exit from the ensemble itself. So this is an example of the for-donning checklist so that you can make sure that someone's cleared and that they don't have anything that's ongoing, and kind of a self-rating of how are they feeling today physically, how are they feeling emotionally, how are they feeling in terms of clear-headed, and since pregnancy comes up from time to time, to be sure to ask about that. So this is a good list to go through, separate from the initial clearance, just before they don and doff every day. And then this next slide is once people take the equipment off, you need to check with them to make sure they didn't have a needle stick, they didn't have an exposure, and also how are they doing physically, how are they feeling emotionally, how are they feeling cognitively. The experience in many of these teams and Africa has been that if you wait until several days have passed of a very intense engagement on Ebola team work, and then say, well, did you have an exposure or a potential needle stick? If people try to go back and think carefully, it may be lost in the fog of the experience. So it's important to do these before and after. And I think that is my last slide, and so I'll turn the baton over to Michael Sari, who's going to talk to us about exposures, and then we'll come to questions at the end.
All right. Thank you, Dr. Hudson and Dr. Swift. My task in the next 15 minutes will be addressing post-exposure management with respect to Ebola virus. It should be stated that this is a rapidly changing topic, including the recent developments of some promising antiviral agents and vaccines. I will begin the section by giving a brief overview, and then we'll discuss some of the recent developments that may change significantly how we manage Ebola virus disease exposures in the future. One of Ebola virus's primary targets, as we know, like SARS, has been healthcare workers. 499 of the 828 healthcare workers infected in West Africa have died from the most recent Ebola virus epidemic. Consequently, all healthcare worker exposures during the care of an Ebola victim is, by definition, high risk. Local county health departments are tasked to accomplish the direct active monitoring, as Dr. Swift mentioned. There is currently no FDA-approved post-exposure prophylaxis or treatment options beyond observation. Any diagnostic tests like PCR or treatment would be only performed after the exposed individual becomes symptomatic or hospitalized, and only with CDC's approval. The majority of exposures in the U.S. Healthcare workers would likely occur at an Ebola treatment center or Ebola assessment hospital. Other high-risk exposures within the U.S. are likely to be family members, EMS workers, healthcare workers at acute care hospitals where their exposures occurred prior to the diagnosis of infection in the index case. The only other high-risk exposure would be a laboratory exposure in an EVD researcher. As with most diseases, the route of entry into the host can significantly alter the rate of clinical presentation. Since the first outbreak of Ebola virus in Zaire in '76, it was noted that injection via contaminated needles was 100% efficient in transmitting EBD compared to 80% of exposures via the skin break or mucous membranes. In addition, the incubation period is found to be shorter via percutaneous exposure, 6.3 days compared to 9.5. This would argue for the immediate transfer to a Tier 1 hospital or consideration for experimental therapies for Ebola needle stick exposure victims. Controversial treatments that have been noted following EVD exposures have been squeezing the puncture wound to express blood. This has been a disproven folklore treatment. Cutting down to the base of a puncture site, which is similar to what is done with simian B virus and rabies post-exposure prophylaxis, and decontaminating the surface with envelope virus antiseptics. Currently, CDC is requesting that non-envelope antiseptics be used, sort of upping the ante a little bit in disinfectant. Immediate treatment following a mucocutaneous exposure is 15 minutes of copious irrigation of the mucous membranes with saline and additional surface decontamination following removal of personal protective equipment. And again, don't forget to assess the risk of other blood-borne pathogens like HIV, hepatitis B, and hepatitis C. The time frame for the disease is illustrated on this cartoon and can be accelerated by the presence of concurrent infections and conditions. By the 7th day of symptoms, it becomes clinically evident whether the patient is improving or deteriorating. In addition, it becomes evident that from the recent literature that there is a protracted and disabling post-Ebola syndrome that is emerging, that is manifested by vision problems, joint pain, hair and memory loss, anxiety attacks, and amenorrhea. Despite the courageous efforts of the missionary and Medicina Sans Fronteras doctors to contain and treat patients during the past 24 Ebola virus disease outbreaks, most of the care of these patients was provided at rural hospitals with severely limited resources. Often the epidemic in these previous epidemics were controlled simply by discouraging the repeat use of syringes and supplying gloves, soap, and running water to healthcare workers and patients. The major breakthrough in the understanding of the pathophysiology of Ebola virus disease is actually occurring during this 25th epidemic. It is only after the EVD patients were given the opportunity to benefit from intensive care available at state-of-the-art hospitals that the key pathological disturbances were identified and addressed to improve the survival of these patients. In addition to treating concurrent infections, and malaria is an important one, understanding the critical pathological process, which is the capillary leak syndrome, led to improved survival outcomes, which pretty much were accomplished by aggressive IV volume resuscitation, aggressive potassium replacement, ventilatory support, and dialysis support. The rapid fluid loss of Ebola virus disease is reminiscent of cholera prior to the advent of oral rehydration solutions. Ebola patients, like cholera patients, can require 14 liters of fluid a day to compensate for the volume depletion due to the virus-mediated capillary leak syndrome and profuse diarrhea during the wet stage of the disease. Currently, we are relying on syndromic surveillance, as Dr. Swift mentioned, for initial screening as well as direct active monitoring following exposure. The current available diagnostic test within a few days of symptoms is the ELISA, IgM, and PCR, as well as virus isolation. Later on in disease is when IgM and IgG antibodies become of some value. Retrospectively, in deceased patients, immunohistochemistry, PCR, and virus isolation have been used. It should be noted that the Ebola virus disease PCR test use must be approved by the CDC, even if it's available at your state lab. And PCR tests have been shown to be negative up to 3 days after the onset of the symptoms of Ebola. A promising new diagnostic test includes the protein microarray technology. This allows the ability to screen for specific antibody responses to a number of species of Ebola and Marburg viruses by multiplex protein microarrays. It's simple, it's quick, and it only requires microliters of the patient's blood. And in West Africa, it can be used as a low-cost point-of-care assay that could expedite the diagnosis and allow for serological surveillance in endemic countries with limited health resources. Other promising developments have been in biomarkers to help monitor the patient's clinical progression. Certain negative markers have been identified in fatal cases, such as elevated AST, elevated D-dimer, elevated BUN and creatinine, reduced levels of calcium and albumin. With respect to immune dysfunction, biomarkers such as elevated cytokines and chemokines, such as interleukin 8, have been helpful, as well as increased C-reactive protein and increased serum amyloid antigen. Another clinical laboratory biomarker indicating coagulation and endothelial vascular injury has been the increase in ferritin as well as thrombomeludin levels, which is a target of Ebola virus glycoproteins binding to the protein C, which reduces, is required to reduce vascular injury, and this is considered part of the problem with permeability of the blood vessel walls. With respect to immunotherapies in Ebola virus, ever since the first outbreak of Ebola, attempts have been made to use passive immunization with convalescent serum from EBD survivors. Unfortunately, all of these attempts have been rather disappointing. Off-label use of some standard therapies is promising. Amiodarone, which is a cheap, well-known antiarrhythmic, has been helpful in reducing the entry of filoviruses because of its multi-ion channel inhibitor activity, and is currently being used at phase 3 by Emergency, an Italian NGO in West Africa. There's also been accelerated vaccine development that is now in phase 3 in West Africa. There is Novavax has a purified glycoprotein, and the two chimeric vaccines that are one from GlaxoSmithKline using a adenovirus backbone against the Zaire Ebola virus and Sudan Ebola virus glycoprotein genes, and New Link Genetics, which is using a vesicular stomatitis virus backbone in order to protect against the Zaire Ebola virus. These vaccines have been found to be almost 100% protective in non-human primate studies. Some interesting novel therapies have been the use of antiviral monoclonal therapy. ZMapp, a treatment that was originally developed for anthrax treatment, is a novel monoclonal therapy which is a cocktail of 3 humanized mouse monoclonal antibodies that is transfected and amplified in tobacco plants. There are some limited human trials where 4 survived but 2 died, and the non-human primate studies seem to show 100% survival. So this is a promising therapy. Also, in addition, there is RNA polymerase inhibitors similar to what we see in HIV treatment. Small interfering RNA compounds. Favipiravir from Japan was initially created to address pandemic flu, but seems to be active. And also cidofovir, which is a prodrug of cidofovir, appears to be a very promising agent. Unfortunately, the arrival of these novel antiviral agents and vaccines to West Africa came at the same time that this most recent outbreak started to wane. Consequently, with the decommissioning of the Ebola treatment units, major pharmaceutical companies canceled their planned double-blind controlled clinical studies. As a result, some of the safety and side effect information may be obtained, but the efficacy of these novel antiviral agents and vaccines will not be able to be determined. Also, these vaccines are being considered for pre-exposure prophylaxis, and obviously that is the major purpose of a vaccine, and so they are also being tested in the general population there. So from the standpoint of what questions are still open, it remains unclear as to what point CDC Emergency Response Team, or CERT, will recommend the use of these experimental diagnostic and biomarker tests, these novel therapies, and also at what point will they feel that a patient needs to be transferred to NIH, Emory, or Nebraska from another Tier 1 institution. An example might be needle stick exposure. Finally, I'd just like to give you a set of references concerning these novel EBV disease biomarkers and therapy. This concludes my segment on post-exposure management of Ebola virus disease. Before we go on to question and answers, I'd like to say that on behalf of Dr. Swift and Dr. Hudson and myself, I'd like to thank Nick Falco of ACOEM for arranging and making this webinar possible. Thank you.
Thank you. We will now begin the question and answer session. If you have a question, please press star, then 1 on your touch-tone phone. If you wish to be removed from the queue, please press the pound sign or the hash key. There will be a delay before the first question is announced. If you are using a speakerphone, you may need to pick up the handset first before pressing the numbers. Once again, if you have a question, please press star, then 1 on your touch-tone phone. We have a question online from Lisa. Please go ahead.
Hi, I'm wondering if there's any recommendations for any adjunct to a physical exam for clearance for this team, for Ebola team members, such as EKGs, pulmonary function testing, anything like that?
This is Dr. Hudson. I'll take that one, I guess. You know, I think it's very case specific, and if an occupational medicine physician feels that it would help clarify the person's underlying condition by getting a treadmill or a pulmonary function test, spirometry, I think that's entirely within the realm of what's reasonable. Sometimes we're communicating with cardiologists and others who have the records already to avoid a repeat test, and I think that's appropriate as well.
If I could add to that.
Are we going to be able to get a copy of the slides too?
Yes. Yes. And if I could add to that, this is why it's so important that you have a conversation with the individual and not just rely upon information that you're getting in a questionnaire, because the different roles on the team are going to imply a different physical demand. So you may have someone who's on the team as, say, an infectious disease consultant, and their time in the room may be very brief, and they may not be doing any patient transfers or turning or lifting when they're there. Whereas the nurse who's in the room for a longer period of time might have a much higher physical demand. So even 2 healthcare workers with the same condition may require a different workup. And Nick, did you want to address how people get the slides?
Yes, the presentation and slides will all be placed on the IDEA Marketplace on the ACOEM website. So if you go into the membership section of My ACOEM, and you'll be able to download the presentation there.
You know, if I can also add to that, Nick, The guidance document and the little checklist that I went through on my slides are available as separate documents on the IDEA Marketplace as well. There are 3 different PDFs, so they are currently available if you want those original source documents in addition to the slides. So when you go to the IDEA Marketplace, you go to Ebola, and they are among the first things listed as you scroll down.
Once again, for any questions, that's star then 1 on your touch-tone phone. And it looks like we have no questions online at this time.
Well, I'd like to thank everyone who's called in. We had an initial Medical Center Section conference call to discuss these issues of clearance and post-exposure management, and those seem to be the areas around which we had the greatest need to kind of standardize. I think in the ensuing couple of months, we've either gotten comfortable or more organized, perhaps just a little less panicky. But I think it was a good experience to pull together our section and get some common ground out there for folks, and I hope that people will find it useful. And it is something that I think needs to continue to evolve as we learn more about the disease, especially as we learn more about post-exposure management.
Yeah, if I can just add one closing comment about the clearance process. I don't know what it's like at other treatment centers, but here at UCLA, it was a mad scramble to get the training, the ensemble, then the regulations changed to then adjust the ensemble, adjust the training, get the volunteer process up and running. And the clearance process was sort of an afterthought. And in all honesty and in the spirit of transparency, it's not fully baked into our process at this point. I suspect that may be true at many of the treatment hospitals in terms of making sure clearance is part of the whole matriculation into being an Ebola team member process. I don't think it's there yet. It's certainly not in the regulations. And so this is, at this point, in terms of how real is this, it's really an aspirational process. It's what we think should be done. But I think the reality is a lot of people have scrambled and are well ahead of having this built in, even though we feel it should be there. So if there are no further questions, Melanie and Michael and Nick, I suppose we can wrap up and let everybody go.
Yes, we can. Thank you all for your participation. Thank you, ladies and gentlemen. That concludes our conference call for today. Thank you for participating. You can now disconnect.